Welcome to the NEI podcast. In today's episode, we're coming to you from the 2023 NEI Congress in Colorado Springs, Colorado. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hello, my name is Dr. Laxman Bahroo, and I'll be answering your questions about my presentation, Neurology for Psychiatrists. First question. I've heard serotonin syndrome can only be caused by MAOIs. That's not necessarily true. MAOIs certainly can contribute to it, and it makes sense. MAOs added to another serotonergic medication, SSRI, SNRI combination. Those are other hidden serotonergic medications can certainly precipitate it, and especially in somebody who's more sensitive to it. So it's one of those things we got to look out for. If you add this and they notice an increase in their tremor portion of it, we may be dealing with very mild serotonergic medication, serotonin syndrome in that sense. And the next question related to that are there differences in the risk of serotonin syndrome when using different types of MAOs? And yes, there is actually. So what happens is when we use MAO-Bs, they should be less likely to cause serotonergic syndrome. That's so far. If they're selective Bs, like for example, selegiline is a selective B at 5 milligrams BID, which is the Parkinson's dose. But when used in psychiatry, it's actually used at 50 milligrams BID, designed to lose its serotonergic activity of B-specific to go to A. So if you have A-specific or non-specific MAOs, then that is much more likely to cause serotonin syndrome because you're dealing with MAO-As. So Bs at high doses, selegiline at 50 milligrams BID, or if you're using MAO non-specifics, then certainly in combination with SSRIs. But as I just described in my conversation, in my talk, was that I had a person on an SSRI or SNRI plus a tramadol medication, and I had him on MAO-Bs as well. So possibly I thought it was all precipitating 3, so I actually had him back down on one or both of the medications to see if we could do that. Another interesting question related to serotonin syndrome is serotonin syndrome concerned for HIV medications when they need an antidepressant? Possibly true, because some of the antiretrovirals can certainly be interacting with antidepressants. Please check those interactions before you start an antidepressant. And of course, start the antidepressant at a lower dosage than you might need to, because again, the concern for serotonin syndrome issues in that sense. Can lithium contribute to serotonin syndrome? I see a lot of questions on serotonin syndrome, so I'm glad we did that as a topic. So this was actually an interesting issue. The question is twofold, because if you look at serotonin syndromes with lithium linked to another serotonergic medication, it's on the list. It makes me think of two possibilities. One, well, lithium can cause tremor and SSRIs can cause tremor. And are we looking at somebody with an additive effect of tremor, and that may be thought of as serotonin syndrome? That's one possibility. The other possibility is one looks at a deeper dive at the lithium mechanism of action. There's a thought process that lithium actually increases the release of serotonin. This is the mood stabilizing effects of lithium. If that's the case, adding a serotonergic medication on top can certainly precipitate or put you at higher risk for serotonin syndrome. So I can see both possibilities in this situation. And in reality, I've seen individuals come in with lithium and a serotonergic medication and tremor, and I've told them that both medications could possibly contribute to the tremor, but it's an important thing to think about that there may be more to it than that, and there may be actually more issues with maybe mild subclinical serotonin syndrome that doesn't require somebody to go to the hospital, but they may have diarrhea, tremor, increased reflexes, amongst other things. So would amantadine be an effective medication to reduce tremor in somebody on an SSRI? They've already failed Inderal. So let's talk about the mechanism of amantadine first. The mechanism of amantadine is basically an NMDA receptor antagonist, and it's basically an antagonist. So the way it works at the level of the basal ganglia is that it reduces glutaminergic activity on top of the neurons at the basal ganglia. Those neurons receive two inputs. They receive glutaminergic input from the cortex as well as dopaminergic inputs from the midbrain. So that's how it works. It modulates the issue of dopamine overstimulation or understimulation with glutaminergic overstimulation. So you're really balancing out both of those. It also has some weak anticholinergic effects. It also has some weak dopaminergic effects. So it's really 3 effects. We really focus on the glutaminergic because that's the most potent portion of it. We don't quite know how amantadine works for tremor. Perhaps it's the glutaminergic effect, perhaps it's the dopaminergic effect, but we do use it for tremor patients in Parkinson's. It's worth trying it. My suggestion would be, is it possible to reduce the SSRI dosage? It may be possible, or maybe if you're dealing with a very sensitive patient, then adding in a medication to reduce the tremor would be a worthwhile discussion to have. Just be careful with adding the amantadine in just to make sure they're not having other side effects of amantadine, dry mouth, or issues with, lightheadedness. So can patients have both drug-induced Parkinsonism and tardive dyskinesia? Yes, they can. Well, if you have receptors that are blocked, they can become hyperactive, resulting in tardive movements that we've talked about. Then that's one of the explanations of tardive, not the only one. And then you can also have underactive receptor activity, which could cause drug-induced Parkinsonism. And yes, you can have mixed, and maybe about 25% of the population would have mixed movement disorder of hyperkinetic tardive dyskinesia and hypoactive drug-induced Parkinsonism. So it can, and it does present some diagnostic challenges. So leading into that question almost beautifully, the second question is, I have an 84-year-old patient on risperidone 1 milligram with left-hand tremor and lip smacking. She also blinks as well, constantly with her left eye. She's on benzotropine and propranolol with no improvement. Started on valbenazine for facial TD. What about tremors? Well, let's talk about that. So the issue is, of course, you have a mixed movement disorder. You have hyperactivity here with the smacking the lips, the eye blinking, for which she's been started on a VMAT tool such as valbenazine. On the other hand, you have this tremor. Now, what do you do with this tremor issue? Well, is it possible first to go back and say, well, with 84-year-old, could we, here's a way to switch. Here's where I would consider a switch. Now, we talked about not switching in the setting of TD because there's no evidence for it. But in the setting of tremor, which is what you're dealing with the left hand, would it be possible to reduce the dose of risperidone? That's one possibility. Would it be possible to switch to another agent? Maybe that's not as anti-dopaminergic. Those would be my two possibilities. I'm a little concerned about benzotropine and anticholinergic in an 84-year-old with cognitive impairment, so that's going to not be my first choice. Propranolol would not be a bad choice for tremor reduction. Even amantadine, which is usually well tolerated in younger individuals, may cause more issues such as hallucinations in the older population. So you're a little bit of a bind. I would say hedge towards subtracting here with the risperidone or alternating the medication to something else to get the tremor better controlled. And again, you don't want to start dopaminergics on this person because they're on risperidone. I have trouble with DAT scan because patients have to be off of all antipsychotropics for a while before they scan. Any suggestions for patients that can't be off meds even for a short period of time? That's a challenge. Not all medications have to be stopped. There are medications that are major medication reductions and then shorter medication reductions. If you look at that label, you'll see that the label will tell you which medications need to absolutely be stopped and which medications do not. Which are giving a great idea for us to do a deeper dive on this discussion because there are a lot of psychotropic medications, longer acting medications that are specifically much more dopamine reuptake inhibitors are more likely to be interfering with the DAT scan. So cocaine, for example, as we discussed, and people chuckled, amphetamines to an extent can be an issue because they're going to work on that dopamine reuptake issues much more. So yes, you may have a little bit of trouble if they can't be off for a short period of time. The next step I would give you that gives you at least a partial answer would be to consider sending them to a neurologist to see if they can do a skin biopsy and get somebody an answer, especially because the answer makes a diagnostic difference, right? Are we dealing with idiopathic Parkinsonism or are we dealing with Parkinson's secondary to medications? It makes a diagnostic difference. It makes a therapeutic difference. You have to set expectations for patients and provide them some guidance. And I think you've reached a fork in the road when you have those considerations. I have a patient on Carblivo and also on Wellbutrin for depression. Do SNRIs change the way Carblivo affects dopamine? It's a very interesting question. In the Parkinson's literature, maybe about 5 to 6 years ago, came out a study looking at which antidepressants work well for Parkinson's patients. Now, remember, the mainstay of Parkinson's depression management by the neurologists was pretty much to use SSRIs. But it actually showed something very interesting. TCAs actually do better for management of depression. And it was thought to be that TCAs do better because they have a mixed mode of action. They're not just working on serotonergic, but they were working on dopaminergic or even norepinephrine. And that mixed mode helps not just with the depression, but some of the fatigue and apathy. Here's the downside of that study. Problem was TCAs, because they also have anticholinergic activity, caused some problems. So cognitive blunting issues, cognitive slowing. So it's kind of a mixed blessing or blessing in disguise or blessing and a curse, however you want to think about it. It really was two different things. And so there were two people that looked at the study. One said, well, this is an interesting signal to look at TCAs. The other group looked at it and said, well, this is terrible. How can we fix the problem to create another one? Well, SNRIs have mixed mode of action. And so it may be interesting to use SNRIs in these individuals to help with some of these components of it. And I know that full well some SNRIs at higher dosages that work on dopaminergics will have some pro-dopaminergic benefit as well. But carb-levo, remember, it acts upstream. It allows the dopamine to be released more. This reduces the reuptake of the dopamine. So yes, it may be helpful in some ways. My concern only is SNRIs are a good class because they give you that mixed mode of action for antidepressants. But getting up to that higher dosage with SNRIs to get that multiple actions of norepinephrine, serotonin, and to get dopamine, such as with venlafaxine, you might not be able to get them to tolerate the higher dosages at an older population. Do you see any relationship between REM behavioral disorder in Parkinson's patients and psychosis emergence? Interesting question, a little complicated answer, but I like the question. REM behavioral disorder in Parkinson's certainly has a correlation with it. If individuals develop REM behavioral disorder, we get concerned that they have some pathology that may increase their risk of Parkinson's. This has been known since in the neurology literature since probably about 2009 or so. I think that's when the Green Journal Neurology article came out. And since then, the link has only gotten stronger as we've been able to better image and scan individuals. So in that sense, there's a link there. There's an interesting link between psychosis and REM behavioral disorder. REM behavioral disorder is basically seeing and acting out dreams, vivid dreams, vocalizations. And there's a spectrum to it from anywhere from vivid dreams in the mildest to really active dreams and acting out dreams at night. With psychosis emergence, sometimes we see in individuals who are developing psychosis or about to develop psychosis, we see that they have vivid active dreams that they act out, and they go from being asleep to waking up and still seeing that dream. So the dream now intrudes from the sleep state into the wakeful state. That's interesting because then you're no longer classifying it as a dream. Now you're starting to see the emergence of hallucinations. So if somebody says to me, a patient's caregiver says to me, or a family member says, they always had vivid dreams off and on, but now we're seeing that the vivid dreams are vivid. We wake them up and they go from there and they're talking about their dream and they're acting out their dream and they're not in reality. They're still in the dream reality, but they're awake. Then I'm thinking psychosis is emerging. It makes sense because REM behavioral disorder is a brainstem pathology issue. It is a brainstem pathology issue. We're talking about the locus coeruleus. The raphe nuclei pathology is not that far apart. It's also at the brainstem, but it's serotonergic in basis. So one can see the correlation or linkage between the two. I have a Lewy body patient with Capgras solutions. What is the optimal medication? Well, this is an interesting question. So I'm going to address the question in a different way. So your Lewy body patient has psychosis in that sense. So they have they have Lewy body dementia, which will have some aspect of Parkinsonian symptoms with delusions, which would classify them as having psychosis. Now, the optimal medication, in my opinion, would be a medication that does not block dopamine. Plain and simple. Why? Because we know that Lewy body patients are very sensitive to dopaminergic blockade. In fact, that's one of the criteria for Lewy body dementia, because blocking dopaminergic can really, really make them very Parkinsonian. In fact, they're very sensitive to two sets of medications. They're very sensitive to dopamine blockade, and they're very sensitive to dopaminergic. So we have to be very careful with this population on how we treat them. So the best medication, as I mentioned, would be one that does not block dopamine. And the one that does not block dopamine as an antipsychotic is pimavanserin, because it works on a serotonergic system. So it's an interesting thought process to think about. And again, we have data with regards to pimavanserin that looks at individuals with Parkinson's disease psychosis and people with Parkinson's disease psychosis and the setting of dementia, which is the closest data point that I can point to that would point to your Lewy body dementia patient. Is there any evidence of treating PD psychosis earlier to improve long-term course? I would say I would like to think that. I don't have evidence of it. I would like to believe that because at some point we're committing these individuals to taking medications on a daily basis. The hope is that it manages the symptoms. We don't have data on if it improves the long-term outcome. The data is just going to be very difficult to come out. We have to have long-term data of people that are treated versus untreated. We know that over the course of time, untreated hallucinations do progress. So we know that. So treatment certainly provides you benefit in terms of being able to function and being able to have less caregiver issues, etc. I don't know if it would prevent the mousetrap syndrome issue or the mousetrap episode. The reason is because there's so many factors that play into it. Medications will help manage the psychosis issues, but there are other inputs. We've had people that have been medicated and optimized and really managed with their medications for Parkinson's psychosis with pimavanserin, but something else throws off somewhere else. Maybe they have another worsening of medical conditions, or they have some other change in their environment that can really, in the short term, set up a trigger for worsening hallucinations. So I'm not sure if it would really have helped treating it. I think it's important to use the dialogue to say, look, this is what we're concerned about. this might happen at some point. Let's start treating it and manage it. But also at the same time, give them kind of a tools to say, we can manage it by managing the environmental components as well, and explaining to them how psychosis that's stable can become unstable if some of these factors change. I deal with rural clients, and a neurology consult can take a year before my client is seen. What are good treatment options I can prescribe for migraine, aside from topiramate? Well, there's a variety of different medications. I will tell you, I'm not a headache specialist. It's an interesting question. Many times what I recommend, there's so many new headache medications coming out that a headache specialist really is your best option. And if the person living is in a rural environment, it's far away, maybe even a virtual visit might be helpful for them with a headache specialist than a general neurologist, because there's so many newer medications. Topiramate is something that's been established. I've been using topiramate even when I was in residency, and that was, well over, 15 years ago. But there are newer medications that have come out that act on CGRPs, newer target medications. People will use medications like valproic acid as well to help with prophylaxis of migraines. So the migraine medications really divide into kind of 2, possibly 3 groups. The first group is, treating them with the acute migraine. So that's medications that you'd use, like triptans and the CGRP medications that you can use. And then there's maintenance medications that reduce overall topiramate, valproic acid, amongst others. Even levetiracetam has been utilized for it. Just be careful and be aware of the side effects of each of those medications. So it's helpful to have both an abortive and somebody's having lots of regular headaches, even, and using those abortives to really look at that prophylaxis. Propranolol has been used as well, so there's no shortage of medications, but really crafting an overall strategy to manage headaches with acute and with medications that manage some of the prophylaxis would be helpful. That's all the time we have. Thank you very much for your questions. I hope the answers are useful and helpful to your practice. Take care.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.